One of the unpleasant bedfellows of dysautonomia is POTS, or Postural Orthostatic Tachycardia Syndrome. In this, episode 5 of our expert interview series, Dr Asad Khan and I talked to cardiology consultant Dr Nick Gall, one of the UK's leading experts on the condition. There's actually a huge amount to cover in this topic, so it's quite a long interview, but one that could be incredibly helpful for those of you out there for whom the condition is making life a bit of a misery. So if you need to, perhaps watch it in chunks. Otherwise, hope you enjoy. So thanks for joining us, Nick. Incredibly kind of you. I was wondering if, first of all, you could just tell us a little bit about your clinical background.
Okay, well, thank you very much for inviting me. So I'm a consultant cardiologist at King's College Hospital in London. So my training is in cardiology, and then I trained as a heart rhythm expert. So right at the start of my practice, it was mostly involving managing brady and tachyarrhythmias, ablations, pacing, complex devices, and so forth. But then I began to become more interested in collapse and blackouts, which then led me on to seeing patients with POTS. And I suppose I've been seeing patients with POTS now for 15, 16, 17 years. And because there's a sort of an interesting overlap between cardiology and neurology. And what was clear then, which I think is probably clear now, is that there aren't that many people who are interested in it. And so it felt that it would be worthwhile sort of developing our process at King's to manage that. And essentially, I've progressed from seeing 1 or 2 patients a month to 4 clinics a week, trying to keep on top of the POTS and dysautonomia patients that are around in the UK.
And how surprised were you that the coronavirus pandemic has led to this sudden wave of patients who've suffered an infection and are now suffering from various forms of dysautonomia and POTS? Is this something that you would have expected?
An interesting question. I suppose that the short answer is yes and no. So when we talk to POTS patients, a lot of people will say all of my symptoms began after some sort of immune insult. And that might be a vaccination for some, but for a lot of people, it's a viral illness. And up until this point, glandular fever has been the commonest. So we certainly hear that story very frequently, that a viral illness can produce it. But I think what has been surprising with all of this is just how many people are presenting with POTS or appear to be presenting with POTS associated with COVID. Now, whether that is because the virus has something about it that will induce POTS, or whether this is just the fact that it's a novel virus and therefore there are an awful lot of people who are being exposed to it in one go, I don't know that we know.
So Nick, what is the range of cardiac complications that you're seeing with long COVID?
You'll have to realise that I am an incredibly biased sample.
Of course.
So people refer to me to consider POTS. They don't refer to me to consider long COVID, and they don't refer to me to consider myocarditis. So I'm certainly seeing a lot of people who have developed cardiovascular dysregulation, a number of cardiovascular symptoms after COVID, and then we are investigating for POTS. I've seen a few people who have clearly had a cardiac MRI scan who've got a diagnosis of myocarditis, but I'm really not the right sort of person who is being referred myocarditis patients. So exactly how common that is, I don't know, and I suspect only time will tell.
And what are the range of symptoms that the patients are presenting to you with?
So they're very. So I suppose in general, when somebody comes to me with POTS, it's cardiovascular dysregulation. So it sounds like a heart problem. So there will be chest tightness, often associated with breathlessness. Usually this is to do with activity or being stood upright. There will be breathlessness, and it's breathlessness on exertion. And often breathlessness that I can't quite get enough air in, there isn't quite enough air around. So something that I think we've come to recognize as rather typical of dysfunctional breathing. Lots of palpitation, but again, fast, regular. When I'm doing activity, everything seems to be faster than it should be. It slows down too slowly, it slows down gradually. And then dizzy spells and faintness. So again, faintness standing up, relieved by lying flat, some risk of fainting and losing consciousness. But and those are very typical POTS symptoms. What again we're recognizing is that as with normal POTS patients, it is often it's a dysregulatory process that affects the rest of the body. So there will be many who are describing migraines, many are describing bowel disturbance of some form, sickness, vomiting, bloating, constipation, diarrhea. Some are describing bladder dysfunction. Some are describing neuropathic features. So there's a vast range which don't necessarily feel like they should all link up unless you think that this is some abnormality in the regulation of the autonomic nervous system, and then it seems to be, then it all seems to fit together.
Yeah, you've described my symptoms to a T, basically. So the breathlessness felt exactly like I couldn't get a deep enough breath in. And I think prior to becoming more aware of dysautonomia, that was one of the symptoms when I would see patients at a respiratory clinic and think, I don't know what's going on here. I wonder if this is even organic, but it definitely is, and there's no other way of describing it. Can I just ask you then, along those lines, what is the mechanism of the coat hanger discomfort that some people describe in this condition? And interestingly, some people have reported feeling a similar sensation in the abdomen, and it seems to move exact location as well. What is actually going on there?
I would suspect that the easy answer is that nobody knows, because really people haven't taken a lot of these symptoms very seriously. So the classical coat hanger headache of neck and discomfort across the shoulders is said to occur classically with orthostatic hypotension. And it is said that it's the large muscles in the back and the neck, which we use to maintain our posture, that become ischemic. So as the blood pressure drops, those muscles become ischemic, and then they ache. And then when patients lie flat, they get their blood supply back again, and those symptoms improve. A lot of the other sort of associated symptoms, many patients will describe as pooling. And people will say, whenever I stand up, I get this odd sensation in my legs. They ache, they feel full, they feel uncomfortable. Similarly, people may get it in the abdomen. Whether truly actually it is blood that is accumulating and therefore it's a stretch phenomenon, I don't know. Certainly one review article I read about why POTS patients get purple feet was that it wasn't the accumulation of venous blood, it was blood being sucked out of the skin. So it's the skin becoming relatively ischemic. Right. But, you know, I mean, my understanding is that there is very little understanding of it. It's just one of those things that is difficult to pin down, but the more POTS patients you talk to, the more they all describe it. Or not all of them describe it, but a number of people will describe that group of symptoms.
And I was just wondering, in terms of the presentation of these symptoms, just how disabling they are. What kind of impact are these symptoms having on people's lives, sort of the patients who are being referred to you?
Sure. There is a huge range. And I think this is one of the problems with POTS per se, is that when they defined it as a condition, they didn't really understand what it was. We still don't really understand what it is. And so it was very specifically defined as a heart rate increase on standing of 30. which was purely based on statistics. It was 2 standard deviations away from the mean. So essentially, it was defined very specifically, but in fact, what we see is a large range, a continuum of patients who have these groups of symptoms, whether they're post-COVID or not. And so there are people who are POTSy, who may be hypermobile, who have put up with their symptoms and just say, well, you know, I feel a little bit limited on exercise. I don't like standing in queues. I've always exercised by swimming and I just don't go running because I'm rubbish at running. Whereas actually when you delve in, you realize that it's the dysregulation of their system that's the problem. But then and there's probably a very large number of people out there, younger women particularly, who are just putting up with those symptoms and just thought, oh, I thought this was normal. But then you can take that all the way to the end to people who are often labeled as chronic fatigue syndrome, who are disabled in bed. They haven't got out of bed for 5 years. They essentially are lying in a bed in a dark room, unable to move because their symptoms are so significant. And because it can link in with hypermobility in some, because it can be associated with abnormalities in the autonomic control of different organ systems, there may be people who are profoundly affected by fatigue. There may be people whose gut really has stopped working, so they're on TPN or they're being peg fed. And there are those who are affected by the POTS, so they just can't get up without feeling faint.
Yeah. I mean, that certainly seems very consistent with what we're seeing with long COVID. There is this huge range of dysautonomic symptoms. There's a spectrum, if you like, of people who have, I think it almost seems like everybody with long COVID has some degree of dysautonomia going on. And some of them may just not have identified it, through to the people for whom it's utterly disabling. I've got one question that's kind of in 2 parts here. And that is, what does the science say about dysfunction of the autonomic system after a viral infection? And the other part of it is, what do you think is actually going on in the body after a COVID infection, that the mechanism of disease, if you like, for dysautonomia in long COVID? So is there a gap between what the science says and what you think is going on, simply because it hasn't caught up yet, right?
Well, I think that's very true. My understanding of the sort of the post-COVID, long COVID POTS is that the literature revolves around a few small series of patients and single case studies. So as far as I'm aware, I don't know that anybody understands it. There are a number of review articles out there, and there's some basic science that has been undertaken to look at POTS in general, and you can find those. Satish Raj, who's a professor of cardiology and autonomics in Calgary, is major expert, and if somebody wanted to look for the current review articles, then search for him on PubMed, and you'll find something. So there are small studies that look at volume regulation and showing that volume regulation in the kidneys may be abnormal. There are small studies showing that vascular regulation and nitric oxide synthase is abnormal. There are small studies that are showing abnormalities in small nerve fiber function. So there's little bits out there that are sort of suggesting, for some people it's an abnormality in heart rate control, for some people it's a failure of blood vessels to tighten, for some people it's an abnormality in heart rate control. Now, we have a neurophysiologist at King's who can do physiological assessments of small nerve fibers. And it seems that small nerve fibers are quite difficult to study, but these are the pain fibers, and these are the autonomic control system fibers, as far as I understand it. And of course, remembering I'm a cardiologist and not a neurologist. So, but we do hear a lot of neuropathic symptoms to a cardiologist. And he's been measuring these small nerve fibers and finding that they're abnormal. And then we've been sending patients off to our peripheral nerve neurologists, and they're saying, yes, you have a small fiber peripheral neuropathy. And so what is increasingly clear that there is some suggestion that a proportion of POTS patients have a small fibre neuropathy, and that it's these little small fibres that are going to the blood vessels and failing to vasoconstrict, and then that gives potsiness, and then they will also be the ones that go into the gut or to the bladder, or to the skin, and then produce the sort of the pain that we see. Because there is this recurring story of I was fine, then I became ill with a viral illness, a chronic infection. There is certainly discussions in the POTS literature to say this sounds like it's an autoimmune condition. And there's certainly some research out there looking at various autoantibodies, although to date, as far as I'm aware, there isn't a single autoantibody. It's just there's lots of autoantibodies out there that seem to be positive. So I suppose, the way that I'm starting to think about this is, are we likely to find out that what this is an autoimmune, viral-induced, small fibre neuropathy that has damaged all these little nerve fibres, and that's why patients are having all of these symptoms. Whether that's true or not, or whether that applies to everybody, I don't think we know. And then somewhere in this, there then seems to also be a link to histamine. And again, there's recurring themes from normal POTS patients, but also long COVID patients, of descriptions of I've suddenly become allergic, I'm suddenly inflamed, I'm getting strange itchy rashes and that sort of thing, and I feel strangely better on antihistamines. And again, there seems to be an association associated with POTS. In the form of mast cell activation syndrome, where patients feel better on histamine, antihistamines. How it all links up together, I don't think anybody knows. And really, up until this point, mast cell activation and the histamine issues has very much been an extremely controversial area as to whether it actually exists or not. But we're hearing the stories. People seem to be getting better with antihistamines. So there's something in it.
Yeah, absolutely. And I think what you've said is going to be incredibly validating for a lot of the people watching this video, because this is what they're saying. They've suddenly become allergic. They've suddenly developed urticaria and various sort of food intolerances. And that coincides with the onset of all of these other symptoms. What's interesting is that there's anecdotal stories of patients being put on steroids, probably because the urticaria was so bad, and everything else seemed to settle down, yes. Including the tachycardia, including the coat hanger sensation. So this is going to probably turn out to be autoimmune, as we think and as you've suggested. So on the topic of POTS in general, before long COVID was identified, which sorts of patients were you seeing the condition in?
So in general, on average, it is a young person's condition, and mostly a young woman's condition. So I suppose 80%, 85% of our patients are female, and the classical patient is between 15 and 35. Often with some history of hypermobility beforehand, and then symptoms being precipitated. In fact, there's often two different groups of patients. There seems to be they seem to be mildly hypermobile or not hypermobile at all, but they've had a significant immune insult, then they develop POTS, or perhaps more significant hypermobility, and they don't necessarily feel that they need to have the immune insult. It's the hypermobility that has associated with it. So that would be the classic patient. We as I say, a smaller number of our patients are male, and there doesn't seem to be anything necessarily different about the boys and the girls, as it were. It's an interesting area that for years POTS has been controversial. It doesn't exist. It's made up by private cardiologists, was often what we would hear. I mean, now we have international guidelines from the Heart Rhythm Society. It's mentioned in the European Cardiac Society guidelines for syncope. The Canadian Cardiovascular Society have produced guidance. It's very difficult these days, I think, for many people to deny, the POTS deniers, that it doesn't exist. But interestingly, what that has led to is that now everybody associates every autonomic problem as being POTS. So if it sounds autonomic, we then get referrals for it, and you will realise that the reason for that is that there are so few autonomic neurologists dealing with autonomic failure. There are so few cardiologists who have an interest in the dysregulatory processes. When any of these sorts of things come up, patients are referred, and often I think this patient's got POTS. So we may get referrals for 60-year-old men who I think this patient's got POTS. Obviously, there are a smaller number of those who have had POTS since they were 15, and just it's sort of continued. But people are now using POTS as a label for all things dysautonomic, and obviously the later onset, we then have to start thinking about the more significant forms of autonomic dysfunction relating to other neuropathies or degenerative conditions, and obviously those people need to go and see autonomic neurology.
So how did you treat people who were presenting with sort of dysautonomic and POTS-like symptoms? Was it different for general dysautonomia versus POTS in terms of the kind of treatments? This is before COVID came along. And is it the same now with your long COVID patients? And how effective are those treatments?
So I suppose the management of POTS patients, it actually is very different, or is very different around the world. So if you go to different people, you will get different opinions. And so you have to work, you have to realize that how I manage POTS is different. And that's just because it's, this is what I've developed over 16 or 17 years as to what seems to work. So, and it's very cardiological focused. So our management is make sure we're not missing a heart problem with echo, Holter, cardiopulmonary exercise test, tilt. Blood tests to make sure we're not missing things like thyroid dysfunction, Addison's. Listen to the patients, obviously, and then if they have symptoms in other territories, so if there are bowel symptoms, bladder symptoms, headache, sleep disturbance, joint problems, try to find a clinician who is interested in that area, who can help them with those symptoms. And sometimes that is easier than with certain symptoms than others. We have been lucky enough to find clinicians often are in and around London who have an interest in, say, the regulation of the neural regulation of the bladder. So then if you have bladder problems, our patients are very well served by those reviews. If we work on the principle that this is dysregulation in the cardiovascular system when it comes to POTS, it's the blood volume's too small, the blood vessels don't tighten up, the heart rate's too fast. So therefore the management then of those cardiovascular symptoms is deal with those things. So it's fill up the blood vessels, build up the blood volume, drink more fluid, add more salt. And we've used a 24-hour urine collection for sodium and volume excretion to guide us. There's a tiny amount in the literature suggesting that we should be seeing more than 170 millimoles over 24 hours of sodium excretion. So we try to gauge it. Failure of blood vessels to tighten, so compression clothing, sports compression leggings. Obviously, the literature says says compression tights, grade 2. The reason that I don't tend to prescribe those particularly is partly nobody or a lot of people don't necessarily know how to prescribe compression tights. Often people then get into discussions about, but you need to see a vascular surgeon to agree that you can wear compression tights, even though this is a 17-year-old woman. And then the third thing is there's actually very few patients that I've ever come across who actually want to wear compression tights. when they've seen them. So the sports compression leggings as a compromise do often provide, patients, they're more acceptable for patients. Exercise seems to be very important, and there is some data in the literature particularly from Ben Levine in Dallas. So it's small amounts of horizontal cardiovascular exercise, rowing, recumbent cycling, swimming, gradually increased. So what we hope is that people are all going to be doing as much of all of that as we possibly can. Respiratory physiotherapy seems to be very helpful for the breathing pattern. And our colleagues at King's have published their experience of that. And then it's really a question of saying, if we need to do more, what seems to be the physiology is the heart's too fast, the blood volume's too small, and the blood vessels don't tighten up. So if it's too fast, slow it down with beta blockers and or ivabradine and or pyridostigmine, but different people respond in different ways to different drugs. I've got no idea why, but they do. And so I take a very organized view, start tiny beta blocker, gradually build it up. If it helps, great. If that doesn't work, we try ivabradine. If that doesn't work, we try pyridostigmine. Vasoconstrictor, midodrine, often very effective in POTS, start small, build up. Blood volume too small, salt tablets, fludrocortisone up to 200 micrograms a day. And essentially, I work my way through those, and people try them for a few weeks. They seem to work quickly. Other people try different things. So desmopressin for water retention, clonidine, is tried. There are some other more serious vasoconstrictors like octreotide and droxidopa. These aren't commonly prescribed. I have colleagues in and around London who are expert in their use, and so we tend to then rely on those. But actually, for most people, they seem to respond very well to some combination of all of those. With the antihistamines, it's very difficult because there are so few people to ask. So I've tended to be very empiric and just say, have an H1 and an H2 blocker. And it's cetirizine, loratadine, fexofenadine with one of the H2 blockers in standard doses, and sort of say, if you feel better after over a month, great. Now, obviously, there are one or two clinicians out there who have greater expertise and may be adding ketotifen and montelukast and rupatadine and sodium chromoglycate. But I have to say that I'm not particularly experienced in their prescription, and even things like oral sodium chromoglycate are really quite restricted in who can prescribe. So that side of things is more challenging. But we try to, if it seems to be a big issue, we try to find colleagues, the urticaria clinic at St Thomas's, for instance, if that's a big issue, really to work our way through in an organised fashion these medications. In terms of post-COVID, long COVID POTS, Gould knows, as they say, because, so I mean, my view has been to say, to be very open with patients and say, I don't think we know, we will just have to treat your post-COVID POTS as we treat every other POTS patient, and hope that the same physiology applies and the same processes apply to treatment. It seems in at least some people, and obviously our experience is very, very much in the early stages, that the same problems occur and the same principles apply, but time will tell.
Thank you. I mean, touching on that sort of difficulty in people accessing the right care, because there really is no standardization. There are still huge gaps in awareness amongst our colleagues, and I was recently contacted by a patient on social media saying that they had done a test themselves at home. So they'd done an active stand test, and it was positive because they had the requisite rise in heart rate. And they took it to their GP, who then duly referred them on to a cardiologist after instituting some sort of conservative measures. And then the cardiologist said, and I found this hard to believe, that because there wasn't a postural drop, this was not dysautonomia. Now, clearly that's not required for a POTS diagnosis, but this isn't the first story I've heard of this nature. And given these gaps in awareness, both sort of at a primary care and secondary care level, what is it that patients can do to advocate better for themselves?
I suspect that the way to deal with that side of things is that there is medical literature out there. There are guidelines out there. So as I say, the Heart Rhythm Society in 2015 produced POTS guidance. The latest Canadian Cardiovascular Society consensus statement published last year, or perhaps early this year, has details. My colleagues have put together a lot of information on the spotlight on syncope for the Royal College of General Practitioners, and POTS is mentioned in that. POTS is mentioned in the European Society of Cardiology guidelines on syncope. So I suppose the way to deal with it for patients is to say, look, there are guidelines out there. They're all freely available on the internet, and potentially to actually, print it out, take it along, say, look, here is the information. We obviously try. I work very closely with the POTS UK charity, as you know, and they are doing huge amounts of work to get it out there. We do lots of talks at Heart Rhythm. I've been lucky enough to do talks at the British Cardiovascular Society. So there's lots of information out there. There's lots of people pushing the message, but I think and there's good patient information on the POTS UK website. So I think often it is a question of patients printing out that information, taking it along to their and I mean these days taking it along metaphorically to their Zoom meeting with their physician and saying, look, it does exist. You need to realize that this is not made up and that this is exactly what's going on, and you need to investigate and refer.
Yeah, I think that's incredibly helpful.
Thanks, that's really helpful.
Yeah, because people are going to be waiting a long time to get referred to. There's so few specialists that, I mean, even being able to be referred to one is very difficult. And if they do manage to get onto your referral list, I don't know how long the wait time is to get an appointment with you. So I think, I guess that leads into another question for me, which is alternative therapies for this, which might include things like mindfulness and breath work to help calm down that sympathetic over response, things like maybe acupuncture or cranial osteopathy. Do you see any of your patients doing any of these sorts of treatments? Do they seem to be helpful? Can you see a way in which they might be, or a logic in which they might be?
So we have lots of patients who will try many different things to try to make a difference. I mean, the breath work you describe, obviously, we don't know why POTS patients have dysregulated breathing. We are absolutely of the view that it is not an anxiety phenomenon. So that side of, and as I say, our respiratory physiotherapists at King's have published their experience on it. So that side of things, I think, is fairly clear, that is going to be something that is helpful. From the perspective of acupuncture and cranial osteopathy and other things, I would have to say I am not familiar enough with the scientific basis of those to be able to say how they would help. But there is no doubt that a number of our patients say, I have used this and it has been very helpful. Great. Mindfulness, I mean, obviously, there is, this is a very difficult, potentially unpleasant set of conditions, and being able to cope with all of it and the management of it, I think, is very important. And certainly, many of our patients have found great benefit from clinical psychology input and mindfulness and CBT, but very much on the basis of managing the condition and how I manage the condition, and does this help me feel better, and how can I cope with this all, rather than the sort of the older idea that therefore if I'm getting involved in these sorts of therapies, therefore it is all psychological, and therefore all I require is getting to the madness within, and then you'll find out that I am mad, and okay, right now I can be treated, which was a very old idea. I mean, what we realise is there's such a clear mind-body link, and managing the whole of the patient's system is important. So I think an awful lot of our patients find that sort of approach extremely beneficial. But again, I mean, that can be extremely difficult to access.
Yeah, true. Certainly there's no public sector provision for these things at all. And you alluded to anxiety, and I'm also glad that you specifically said that this was not anxiety, and I think patients will find that very useful to hear and very validating. And I'm also glad that you mentioned chronic fatigue syndrome, ME, where CFS really is a misnomer. It's an organic condition where you do get POTS, and there's a spectrum within that where you've got patients who are tube fed, and then you have got patients who may solely have the fatigue. So I think a lot of patients will find that very useful to hear. But still, there are multiple instances of people being told by their doctors, BPs, be it their ED physicians, that for example, there's signs of tachycardia anxiety.
Yes.
And I've had colleagues, medical colleagues, who've been sent home with heart rates of 140, 150, and have been told that that's anxiety when they've clearly had COVID, and that's what precipitated it. I mean, in the absence of sepsis or hyperthyroidism or other such conditions which might be driving tachycardia, how high would you accept a sign of tachycardia as being due to anxiety? I appreciate there's no definite answer to this, but there has to be some kind of reason here where you say, actually, that's ridiculous. You can't attribute that to anxiety.
I suspect. I mean, the short answer is I have absolutely no idea. In the end, I would suspect that there probably isn't an upper limit to how fast the heart can go in situations of anxiety. But I think I suppose my view, I totally agree with what you say. There are a huge number of people where the symptoms are put down to anxiety, and often because of the demographic, there does seem to be this general feeling out there that young women are always anxious all the time for their entire lives, and so it's therefore very easy to label people. I think that what people need to do is to be very aware that there is a lot more to anxiety and the diagnosis of anxiety than just a heart rate. We have all seen patients, and might be even family members or friends who are anxious. They are not anxious just with a heart rate. They look anxious for other reasons. And so I think the diagnosis has to be based on more than just a fast heart rate. I mean, what's interesting is, there's a small amount of literature in POTS. Are POTS patients, do they have more major psychiatric problems than other parts of the other groups in the population? And the answer is no. But when psychologists have done studies to say, we're going to use a questionnaire to find out whether you're anxious that involves both physical and psychological symptoms, they sound anxious. When they use questionnaires that just are basing the diagnosis, as far as I understand it, on the psychological symptoms of anxiety, they're not more anxious than anybody else. So I don't know that there's an absolute number, but I think there has to be, if you've got a young person in front of you with a heart rate of 170 or 160, and you're wanting to say to them, I think you're anxious, they're not going to be lying there or sitting up there looking absolutely chilled but saying, isn't it interesting, my heart's going quite fast. They're going to look very, very different. And I think so I think you have to look at the whole patient in the context of the heart rate.
Absolutely.
So
Thanks.
I've got a question about the prognosis that you sort of...
Haven't we all?
Fortunately so.
I'd love to know.
I mean, so I guess two parts to this question. And the first is if someone presented to you with EBV or prior EBV, and they now had some form of POTS or dysautonomia that was perhaps in the middle of this spectrum that we've described, what sort of prognosis would you perhaps offer them? And the second part of the question is, how many of your long COVID patients that you've seen over the last number of months do seem to be getting better? And is there anything that you can draw any kind of conclusions from there about what the prognosis might be for long COVID instigated dysautonomia or POTS?
I suppose to take the last question first, the short answer is I don't know. There are clearly people who are improving with long COVID POTS and are noting a slow and gradual improvement. And then there are others who aren't noticing an improvement. I would also have to say that for the standard POTS patient, I never give a prognosis because too often people will come to see me and say, I went to see so-and-so and they said I would grow out of it, but I'm now 25 and I haven't grown out of it. Or it would all be better in 2 years. Well, it's 2 years on and I haven't got any better. And so I think that it's extremely dangerous to try to put a label on it. I think that there are an awful lot of people who do get an awful lot better with POTS. Frankly, I wouldn't get involved in it if it was all going to be incredibly depressing and nobody was improving. Partly, but cardiologists, we're all mad, crazed axe murderers. So we want to see that people improve. We want to do things to make people better. I mean, but I think that it's often not a thing that I do just solely. I think that some of it gets better on its own. Some of it gets better with what we do. And a lot of it gets better with what the patient does. So some of that will be having an understanding of the condition and why it gets worse and why it gets better and what you have to do to keep yourself well, and what you mustn't do because it makes things worse. And then it's having this very organized process of trying to improve the cardiovascular side, but also dealing with all of these other options. So a lot of people do get better, but it's a slow business, and it's often it requires this organised, multidisciplinary management, or that's my impression. I mean, obviously, I have absolutely no data to prove that is the right way of managing it, but it does seem to work for a lot of people.
Okay, thank you. So both Jez and yourself have alluded to the paucity of people with an interest in POTS in particular, dysautonomia in general, and given that certainly in the public sector, patients could be waiting a very, very long time to access a specialist. I don't know what sense you have of at what level GPs are prepared to prescribe at. Certainly anecdotally, what I've found is that they will prescribe beta blockers, suggest conservative measures, which normally the patients have worked out themselves, and then stop. And then the patient doesn't get onto Avabradine, for example, when the beta blockers clearly aren't working or aren't tolerated. And I appreciate, again, that there's no straightforward answer to this, but in primary care, what sort of ceiling of therapeutic trial would you be happy with? And how sort of difficult or risky are these drugs?
So I suspect that there will be differences in different areas. Different CCGs will have different thoughts. I've certainly come across a wide range of experience and opinion in primary care. There are some primary care colleagues who are extremely happy, will review the literature, and actually will have even tried things like midodrine and ivabradine, but potentially because they already have experience or they've seen patients with it and they've gained some confidence and are just desperate to do something for the patient in front of them. There are certainly some primary care groups where things like ivabradine and midodrine are absolutely off the agenda. We will never prescribe this at any point, and it will always have to come from the hospital. There are others where they will take on those prescriptions under guidance. What I would say is, if we're generally happy that we have excluded either sinister or important things like thyroid dysfunction, Addison's, you can use the 24-hour urine collection to guide how well hydrated somebody is. Adding salt tablets, and I use salt tablets very frequently as my first line, and people get a little bit confused. Oh, but their sodium levels are normal in the plasma. You know, they've got normal blood pressure. All salt tablets is a way of guaranteeing how much salt the patient gets into their diet. So it's just a way of saying, have more salt. Because if we just say, I want you to add more salt to your diet, you add more salt to your diet, but neither of us know actually how much is being added and is that enough. So salt tablets are very, very easy to prescribe. They have no monitoring, and all of these interventions seem to work very, very quickly. You know, if somebody's going to notice a difference, they're going to notice a difference in a few days, in a few weeks. You're not having to do it for months. Beta blockers, again, very easily prescribed. Propranolol often is favoured in the POTS world, but often because there's such an overlap with migraine, you can get two benefits from it. We often start at 10 milligrams a day and then slowly build up from there. Fludrocortisone, 100 to 200 micrograms a day. Those I would suspect, you know, those are my essentially first 3-line treatments, and all of them can be prescribed together. And I would hope that there's a lot of experience in primary care with those particular medications to realise actually these aren't particularly dangerous, and I can add all of them together, and if by adding them all up it makes a difference, then that's great. Similarly with the antihistamines that we mentioned earlier, you know, cetirizine and cimetidine, or, you know, cetirizine and famotidine or nizatidine or whatever. So I would hope that, you know, for a lot of people, their primary care physician could say, look, I'll have a go with some of these. If you get referred to general cardiology, and I suspect that this is going to where people will have to go, they're not all going to be able to queue up. You know, I think in discussions, you know, people said 1.1 million patients in the UK with long COVID. That's quite a long waiting list for me, which is already quite prolonged as it is. You know, people are going to have to end up in cardiology, and cardiologists are generally familiar with ivabradine. So it may be that the process for this is simply making sure that we're not missing something, recognizing the symptoms, and in primary care trying the simple therapies, which you can work through fairly quickly. And then simply with general cardiology trying ivabradine, and then, you know, leaving some of the sort of the more complex, nuanced medications where there's much less familiarity, like midodrine, like pyridostigmine, etc., you know, to the clinics where we're using it all day, every day, but other people aren't.
Thank you.
That's really helpful.
Can I put you on the spot a little bit, please, Nick? If you could if you had infinite resources and you could commission a study of your choice and design into something connected to dysautonomia, POTS, and long COVID, what would you really like to find out?
I have so many studies. I suppose, yeah, it wouldn't actually be a study. It would be a project system, to be honest. You know what? I suppose one part of it is we have this feeling that what we do, but also what is done at Barts and at Queen Square and, you know, at the Hammersmith and at the Brompton and in Sheffield and in Newcastle and in Bristol, you know, so there's lots of colleagues around the country who are doing certain amounts of things. That what we do seems to provide benefit. So one part of it is to say, we've already been doing it to some extent at King's and saying we've taken 100 people where we've done cardiopulmonary exercise testing and look at our data, isn't it interesting? My colleagues recently have looked at 100 patients with their bladder disturbance. Isn't it interesting? They've all got neuropathic bladders. So, you know, one part of the study would be to say, look, I'm seeing 500 POTS patients a year. Look at that data. We investigate them in exactly the same way, collect all that information, collect retrospectively and then prospectively what we do, and let's see if we are doing what we think we're doing and is it helping. So that would be one part of the study. A second part of it would be very simplistic studies. You know, Satish Raj has produced a small study looking at salt tablets or salt supplementation and showing that patients feel better. We've got hundreds of people that we put salt tablets on. It shouldn't be very difficult to do big studies to say, you know, if you've got POTS post-COVID or not, do salt tablets make a difference? Does midodrine make a difference? Because there's some, you know, he's done that. There's a small study in hyperadrenergic POTS published in JACC of about 20 people with ivabradine. Most of the rest of the medication studies are tilt-based studies where we gave you a drug, we stood you up and we tried to see whether that made a difference. So it shouldn't be difficult to do these very simple placebo-controlled trials to show that people feel that, you know, that it makes a difference. So to just validate what we're doing so that you can provide it, some understanding. That it's not just that we've all made this up, and then it's taking it further forward. You know, we have this, as I say, we're just putting together a group of patients that we've looked at with a small fibre neuropathy. There's little bits of data out there about the vascular endothelial function. It would be having project grants to say, we need to look at this small fibre neuropathy story more formally to actually say, if sympathetic microneurography is the way to assess it, is biopsy the way to assess it, what other tests do you need to do? Are we actually finding this? So actually what it requires is a whole system of saying, we've got hints about what's going on. We need to organise it and investigate it in an organised fashion.
Yeah, thank you.
Thank you. I'm very conscious that we've taken nearly an hour of your time. So very quickly, apart from POTS, in the context of long COVID, are there other autonomic system disturbances that clinicians and patients need to be aware of?
So, well, I mean, it will be dysregulation in every part of the body. So we as I say, we've seen lots of patients with significant migraines. The migraine treatment is the treatment for migraines. It just needs to be treated, but patients need to be listened to. We've got patients with abdominal dysfunction. We've got patients with bladder dysfunction. We've got patients with their pain and joint dysfunction. So I think it's really a question of recognizing that all of these symptoms do fit together. And there are a small number of clinicians out there who recognize the abnormalities in the nerve control of organ systems can produce as many symptoms and even more troublesome symptoms as more structural abnormalities, and that these need to be taken seriously and managed appropriately.
Yeah, I mean, absolutely listening to the patient is so key. I don't have any further questions. I wonder, Jez, if you do.
I have one question which you can answer quickly, maybe, which is if there was one piece of advice you could give to somebody who's struggling to get their primary care, GP or whatever to help them, or they've maybe just realized that they've got POTS and they've been suffering, what is the one thing that maybe they can do that might help them?
I suspect that the thing to do is to say take ownership of it. So there's a lot of information out there that we've already discussed. So there's lots of guidance from the medical organisations, both the UK and abroad. There is lots of patient information. So there's lots of patient information on the POTS UK website. There's information on STARS, so the National Blackout Charity. So they've got some excellent information. There's information on NHS choices. I think that what it is, it's a question of saying, this is real, get that information, do the simple stuff obsessively well that is there on POTS UK and STARS, but then take that information to your GP and do not take no for an answer. I have this, I want to be referred. Refer me to local cardiology, refer me to, local neurology, refer me to whoever it happens to be. And you just keep going and you keep banging on about it until it becomes easier to say, oh, all right, then I'll refer you, rather than to be fobbed off. Don't be fobbed off, I think is the short answer.
No, absolutely, and that is so important because we have this tendency, and I've come across this, and so have so many other patients, where if it doesn't fit a familiar pattern, it's in the head, and we have to fight that because otherwise we're going to miss these important conditions. So a big thank you from me because this has been amazing and extremely powerful. I'll hand over to Jez for final words.
I just want to say thank you hugely as well. I mean, the reach, hopefully, that this will have to a huge number of people who are suffering, and the ability, it's almost like, an hour of your time here can help thousands of people, hopefully, who can watch this all over the world. So, you might not be able to see them all personally, but hopefully your expertise is helping them in some way. So thank you hugely.
Well, you're very welcome. Thank you very much for asking me, and I hope it's helpful. But of course, the other thing about this new condition, because it's poorly studied, is most of what I've said could be complete rubbish. It may all be entirely untrue in 5 years, but the more we talk about it and the more people take it seriously, the more we are likely to find the answers, rather than, as you say, if I don't understand your symptoms, you're mad.
Yeah, absolutely.
Absolutely. Thank you so much.